Peptic ulcer disease. Peptic ulcer disease (PUD) includes urinary ulcer and gastric ulcer disease. Causes of peptic ulcer disease include Helicobacter pylori most common, and shared second most common due to their effect in inhibiting the production of the protective mucus barrier in the stomach, and shares inhibit prostaglandins and prostaglandins produce the mucus, and shares produce more bleeding than pain. The burns, head trauma, Crohn's disease, gastric cancer, and carcinoma, Zollinger Ensel all are less common, but they also cause peptic ulcer disease. The name peptic ulcer disease is a misnomer based on the mistaken belief that the conditions were caused by the protein-resisting enzyme pepsin. Tip: Alcohol and tobacco do not cause ulcers, they delay the healing of ulcers. Alcohol and tobacco don't cause ulcers, they delay its healing. What is the most likely diagnosis? Peptic ulcer disease presents with recurrent episodes of epigastric pain that is described as dull, sore, and gnawing. Although the most common cause of upper GI bleeding is peptic ulcer disease, the majority of those with ulcers do not bleed. Tenderness and vomiting are unusual. You cannot answer peptic ulcer disease as the most likely diagnosis based on symptoms alone. Testing includes upper endoscopy, most accurate test to distinguish duodenal ulcer and gastric ulcer, and other radiological testing, but it's less cannot it is and H. pylori testing now. Now, upper endoscopy. In those who are to undergo endoscopy, there is no point in doing non-invasive testing such as serology, breath testing, or stool antigen detection. Endoscopy is the only method for detecting gastric ulcer cancer. Cancer is present in 4% of those with gastric ulcer, but in none of those with duodenal ulcer. Radiological testing examines upper GI series to detect ulcers, but cannot detect cancer or H. pylori. H. pylori testing, biopsy is the most accurate test. Now look here. There is no way to diagnose peptic ulcer disease without endoscopy or biopsy. You can't diagnose it. There is no way to distinguish duodenal ulcer, gastric ulcer, gastritis, and non-ulcer dyspepsia without endoscopy. Changes in pain with eating are not specific enough to make diagnosis of duodenal ulcer versus gastric ulcer. Pain during eating, gastric ulcer, and pain relieved by eating, duodenal ulcer. Treatment of peptic ulcer disease. For peptic ulcer disease, proton pump inhibitors effective in far majority of cases but will recur unless H. pylori is eradicated. Duodenal ulcer is associated with H. pylori in 80 to 90% of cases. Gastric ulcer is associated with H. pylori in 50 to 70% of cases. For H. pylori, proton pump inhibitors plus 2 antibiotics is given. Clarithromycin and aloxamoxicillin is preferred, but if the patient is hypersensitive to penicillin, then we can give a different drug. If no response, then metronidazole, levofloxacin, or tetracycline are alternatives. Note this is the only use of tetracycline. And bismuth to a chain of antibiotics may help to resolve treatment-resistant ulcers. We test with stool antigen or breath test to confirm eradication of H. pylori and Helicobacter. Repeat endoscopy for those with gastric ulcer to exclude cancer as a reason for not getting better. Previous clarithromycin uses for other reasons gives 30% failure in its use to treat H. pylori. Now, don't treat asymptomatic Helicobacter, correct? Don't treat it. The only way to exclude cancer is with biopsy. You can test for Helicobacter pylori with non-invasive methods and treat it, but you cannot exclude gastric cancer non-invasively. Only way for gastric cancer is biopsy. Endoscopy with biopsy. Figure 1.8 Helicobacter pylori treatment in peptic ulcer disease. Biopsy positive for H. pylori. Now, no penicillin energy, then we give proton pump inhibitors plus clarithromycin or amoxicillin. And then 30 to 60 days post-therapy to testing for eradication is by urea breath test. If the patient has penicillin energy, then we give proton pump inhibitors plus clarithromycin and metronidazole, not amoxicillin. And then 30 to 60 days post-therapy testing for eradication with urea breath test. Read the scenario. A 56-year-old woman comes to the clinic because the symptoms of gastric pain from an endoscopy confirmed duodenal ulcer have not responded to several weeks of proton pump inhibitors, clarithromycin and amoxicillin. What is the most appropriate next step in management? Urea breath testing. Because if there is no response to duodenal ulcer therapy with proton pump inhibitors, clarithromycin and amoxicillin, first thought should be antibiotic resistance of the organism. Persistent H. pylori infection can be detected with urea breath testing, stool antigen detection, or a repeat endoscopy for biopsy. It would be very hard to choose between these, and that is why they are all not given as choices in this question. If stool endoscopy cannot detect H. pylori, H2 blockers, and sucralfate add nothing to a proton pump inhibitor and have less efficacy, not more. The treatment failure most often stems from bacterial resistance, non-adherence to medications, alcohol, tobacco, and NSAIDs. Now, stress alcohol prophylaxis only with head trauma, burns, intubated patients, sepsis with coagulopathy. Functional non-alcohol dyspepsia. Functional non-alcohol dyspepsia (NUD) is pediatric pain that has no identified etiology. It can only be diagnosed after endoscopy. The pain of non-alcohol dyspepsia can be identical to gastritis, pelvic ulcer disease, gastric cancer, or reflux disease. Functional dyspepsia is a pediatric pain with a normal endoscopy. Non-alcohol dyspepsia is the most common cause of pediatric pain. Treatment is as follows. Age less than 60, treat empirically with anti-secretory therapy such as proton pump inhibitors and scope only if symptoms do not resolve. Age greater than 60 years, endoscopy is definitely indicated to exclude cancer. Non-alcohol dyspepsia is not definitely associated with H. pylori. However, if symptoms do not resolve with initial therapy and H. pylori is present, you will try to treat it. Symptoms persist plus H. pylori is present, treat for H. pylori. Now, scope for dyspepsia, patient is age greater than 60, alarm symptoms are present, dysphagia, weight loss, anemia, or proton pump inhibitors fail to control symptoms. Need to scope. Gastrinoma, Zeuger-Elson syndrome. Less than 1% of those with Alzheimer's disease have a gastrinoma. Correct? Gastrinoma is often associated with diarrhea because acid inactivates lipids. What is the most likely diagnosis? Look for a patient with ulcers that are large, greater than 1 to 2 cm, recurrent after Helicobacter eradication, distal duodenum, and multiple. Once endoscopy confirms the presence of an ulcer, the most accurate diagnostic tests include lab testing. Any of these following will confirm diagnosis. High gastric level of anti-secretory therapy, proton pump inhibitors or H2 blockers. High gastric level despite a high gastric acid output. Persistent high gastric level despite injection secretion. Imaging. Once diagnosis has been confirmed to exclude metastatic disease, abdominal CT/MRI is done first, but as poor sensitivity, that is, a negative test does not exclude metastasis. If CT/MRI is normal, superimposed receptor scintigraphy nuclear ocular scan is combined with endoscopic ultrasound to exclude metastatic disease. Hypercalcemia is the clue for multiple endocrine neoplasm from hyperparathyroidism. Now, the most accurate test is always a functional test, such as looking at the response to secretin. Local disease is removed surgically. Metastatic disease is unresectable and is treated with lifelong proton pump inhibitors to block acid production. Gastrinoma or Zollinger-Ellison syndrome is associated with a massive increase in the number of somatostatin receptors in the abdomen. Diabetic gastroparesis. Long-time diabetes leads to gastric dysmotility. Distension of the stomach and intestine is normally the most important stimulant to motility. Gastroparesis is an autonomic neuropathy leading to dysmotility caused by an inability to withstand stretch in the GI tract. What is the most likely diagnosis? Look for diabetic patient with chronic abdominal discomfort, bloating, and constipation. There is also anorexia, nausea, vomiting, and early satiety. Diabetic patient with abdominal discomfort and bloating. This is the scenario. A 64-year-old patient with diabetes for 20 years comes to the office with several months of abdominal fullness, intermittent nausea, constipation, and a sense of bloating. On the examination, a splash is heard over the stomach on the auscultation of the stomach when moving the patient. What is the most appropriate next step in management? See erythromycin. Answer: because when the diagnosis of diabetic gastroparesis seems unclear, there is no need to do diagnostic testing unless there is a failure of therapy. Erythromycin or metoclopramide increases gastrointestinal motility. Most accurate test for diabetic gastroparesis is the nuclear gastric emptying study, although it is rarely needed. Since diabetes can also be associated with GERD and diarrhea, confirmatory testing may be needed. Best initial test: upper endoscopy or abdominal surgery to exclude a luminal gastric mass or abdominal mass comprising the stomach. Most accurate test for diabetic gastroparesis: bolus of food tagged with technetium, a nuclear isotope, or delay in the emptying of food indicates gastroparesis. The treatment starts with dietary modification, blenderized foods, restored fluids, and corrected potassium and glucose levels. If no response to dietary modification, start metoclopramide. This will reduce induced tardive dyskinesia, dystonia, and movement disorder in 1% of patients. Other words, affect are long QT syndrome and hyperprolactinemia. If metoclopramide is ineffective, answer erythromycin and antiemetics. If all medical treatment fails, do gastric electrical stimulation, gastric pacemaker. Metoclopramide cannot be used permanently. Dystonia and hyperprolactinemia will develop.